So it is the preventing mortality and morbidity from unsafe abortions in Bharat, India. Practical and evidence-based strategies with global lessons. So why we need to know about unsafe abortion? Unsafe abortion contributes almost 8 to 10% of maternal deaths in India. It's the third leading cause of maternal mortality. 10 women die each day in India due to unsafe abortion. So this is a very high figure, and we can bring it down to 0. 67% of all abortions in India are unsafe. It has direct impact on women's health, rights, and demographic goals. I think this slide just speaks about it, why we need to know about unsafe abortion. So what is the definition of unsafe abortion? WHO says that a procedure for terminating a pregnancy performed by persons lacking the necessary skills or in an environment that does not conform to minimum medical standards or both. So abortion is carried out either by unqualified individuals or in settings lacking proper hygiene, equipment, or post-abortion care, or both of the above. So global overview basically says, this is from the Lancet 2017, it says about 2010 to 2014, about the statistics, almost 45% of all abortions worldwide are unsafe, and 97% of them occur in developing countries. So this is pretty higher figure. 25.1 million unsafe abortions took place worldwide each year between 10 to 14, of which 24.3 million, 97%, are in developing countries. So this was the WHO information sheet in 2008, where you can see between, among the world, number of unsafe abortions are almost 21,600. In developed, it is only 360,000, while in developing, it is 21,000 to 100,000. So see the difference between the developed regions and the developing regions, and consequently, there is a vast difference between the contribution to maternal death because of unsafe abortion. And Asia, Eastern Asia, the figures are not available, but it fares pretty well as compared to developed countries. And South Central Asia fares very poorly among the Asia. Southeastern Asia is little better, Western Asia is far better as compared to Eastern Asia. And there's a trend. From 1990 to 2008, there is decline in the number of unsafe abortions conducted worldwide. So this is a very nice infographic which I had found out, that banning abortion endangers women's health. And you know, still there are so many countries, especially in Africa and Latin America, where abortion is not legalized. So if we are banning abortions, there's no legal procedures, no legal acts, so many unintended pregnancies which occur land up in unsafe abortions and cause increased maternal mortality. Almost 225 million women in the developed world have an unmet need for modern contraception. And almost 86% of the abortion take place in the developing world, most of these in countries where abortion laws are highly restrictive. So this is a very important. And you can see the global map. The darker the color, the dark gray, in Latin America, in South America, in Africa, these are the areas where more than 75% of abortions are unsafe. आगे मैम इंडिया पे unsafe abortions in India. So key findings are unintended pregnancies in NFHS 5 is seen as 15.87%, which is lesser as compared to NFHS 3, where it was 31.76% of unintended pregnancies. Unsafe abortions persist as high level, with 67% abortions between 2007 and 2011 deemed unsafe. And maternal mortality is the third leading cause of death in India, accounting for almost 8 to 10 maternal deaths daily. And of all these, 3.4 million occurs in the medical facilities, and almost 11.5, almost 4 times, occurs outside medical settings, which are unsafe. There is a lot of rural and urban disparity. Adolescents and low-income women are at highest risk. So in Lancet 2017, there's a very important study which classified unsafe abortion. So abortions are classified as safe, less safe, and least safe. Safe abortions are done by WHO recommended methods, appropriate for gestational age by trained persons. And almost 55% of worldwide abortions are considered safe. Less safe, 2 of 3 criteria are met. Like if only it's done by a WHO recommended method, appropriate for gestational age, but by untrained individuals, it is less safe. But if all the 3 parameters are not there, it is least safe by untrained person using dangerous, outdated methods like DNC or herbal concoctions, putting in some herbal medicines in the uterus and all those outdated methods. These are least safe and it contributes to about 14% of all abortions. So we have to make sure that we don't have least safe abortion at all. Worldwide. Worldwide. This is a study which was conducted by WHO and UNDAPA in a Guttamack Center in New York. Lancet 2017. So this is the infographic which is from this study that when you see North America, white is all safe abortions. Very small pie is for unsafe abortions. In Europe, this darker maroon color is least safe, this is less safe, and these are safe abortions. You see the pie. So most of these are safe abortions. In Asia, more than 50% is safe when you see all the Eastern and all the parts of Asia combined together. And a small pie is of least safe abortion. So we have more of less safe than least safe abortions. While Africa and Latin America, here the pie is, this is the safe abortion, less than 25%. Almost 25% are less safe, and almost 50% are least safe. And these are the areas, Africa is the continent where most of the countries, they don't have legal abortion guidelines or the acts in place. In Latin America, however, the safe abortions are same about a quarter, and most are, 50% are less safe. They are usually by WHO recommended methods by self-administered MTP pills, similar to those settings. And least safe is about, I think, less than 25%. So the most common cause of unsafe abortion is unintended pregnancy. And why unintended pregnancies cannot have a safe abortion? Because of so many factors, especially the restrictive abortion laws, lack of awareness, limited access to trained providers, myths, stigma, and fear of legal actions. There is delay in seeking abortion, there's a high cost of private care, and family dynamics. So this was one, actually it's a case report which was published from AIMS by Fetal Medicine Forensic Department, where a maternal mortality following a self-administered MTP pill was discussed. In the discussions, they have reasoned that the self-inflicted abortions are due to these causes, strict provisions of MTP Act, especially before 2021, where even unmarried women were not able to have legal services for safe abortions. Socioeconomic problems are there. Social stigma is there. There's minor age pregnancies, adolescent pregnancies, poor accessibility to quality healthcare services for MTPs, easy access to quacks. This is also, I think, one of the most important things. The quacks prescribe, I think, MTP pills more than what the doctors prescribe it. And misleading information about MTPs. So what the MTP Act covers, it covers that a qualified RMP should be performing it, place should be registered for MTP, and a gestational age limit has been set. So 2021 amendment, it's a very liberalized abortion law, though we have medical abortion laws since 1972, but now it has been liberalized. Up to 24 weeks and beyond, under certain conditions, pregnancy can be terminated. Up to 20 weeks, a single RMP practitioner can terminate a pregnancy. Marital status is not required. I think this is a very developing development in the Medical Termination of Pregnancy Act, that marital status is not required. Anyone who is living in a live-in relationship or premarital relationship can, however, still there is a role of RMPs only. No provision for mid-level providers yet, ASHA workers, or nursing persons cannot prescribe MTPs. So the critical gaps. Only 15% of public health facilities offer abortion services. Pharmacists sell medical abortion pills without adequate instruction to the patient. Fear of legal repercussions is there, especially in minor age pregnancies. Lack of post-abortion contraception and a non-acceptance of contraception. This is, I think, last two are very, very important, where we, in our daily practice, we must be, whenever we are offering a medical abortion, we should be telling them about post-abortion contraception, and a non-acceptance of contraception should be evaluated. Why are they not using it? What are the myths? And what are the barriers? And we should really address these issues. So this is the critical gaps leading to high rate of unsafe abortions in India, which has an impact on maternal morbidity and mortality. There is lack of trained providers, especially in remote areas, unsafe procedures then done by unqualified individuals, all leading into unsafe abortions. This legal misinformation, women avoid safe legal options that are available to them very easily. There is a social stigma which causes delay in care, secrecy, unsafe and self-managed abortions, which is pretty common in our day-to-day practice. Poor contraceptive access, there is high unintended pregnancy rates because of poor contraceptive acceptability in the couples. They may be using a barrier contraceptive, but there's inconsistent use, and they don't know the implications of it. And when they land up in pregnancy, they try to self-administer NTP pills. There's legal fear among providers, and there's restricted service availability is there. Cost barriers is also there. Preference for informal or unqualified providers is there because of cost barriers. So the consequences of unsafe abortions are many. However, the most serious consequences are hemorrhage, sepsis, and death. Consequences, others are psychological impact, causes depression, anxiety, post-traumatic stress disorder, guilt, shame, and emotional stress. Social consequences of stigma and discrimination, legal repercussions in restrictive countries, isolation from family, community, or the economic impact. High cost, loss of income due to hospitalization, burden on healthcare systems is there. So what is the way out? Our way has been shown by the developed countries where we have least amount of unsafe abortion. So countries with high rate of safe abortions, most countries in these regions have relatively permissive laws on abortion. There's a high level of contraceptive use, which unfortunately in our country we don't have it. Economic development, gender equality, so that woman has more power, more say in her medical facilities which she wants to avail. High quality health services which are available to all. All these factors contribute to making abortion safer. So we should be able to address all these. First, relative permissive laws of abortion, I think 2021, we have achieved quite a number of it, and rest all we need to work upon. There's proven interventions, global models. So low resource countries, what steps they have taken to decrease unsafe abortion? They legalize abortions in countries where it has not been legalized. They have trained their nurses, their midwives for providing abortion services to decrease unsafe abortions. Nepal. These are mid-level providers which are trained and certified to administer medical abortion pills. Nepal is a country where is geographical inaccessibility to healthcare. There's flooding and roads get wiped away by landslides. People are not able to go to the healthcare facilities. So they're mid-level providers which are trained and certified. They administer the medical abortion pills. In South Africa, law should be more liberal. There are only, I think, 10 countries where abortion is legalized in Africa. Rest all countries, it is not, they don't have the law for abortion. So they need to liberalize law, public sector services and information and education campaigns should be run, and there are many NGOs which are working there in Africa and South America. Bangladesh, their abortion is very, very restrictive. They had their MTP Act way back in 1860, where they don't allow any abortion. What they allow is menstrual regulation, so that patient achieve a state of non-pregnancy when she misses her period. That means by doing a manual vacuum aspiration. So they have a 50 cc syringe attached to a cannula, which we used to have a long time back. That MVA that is legalized up to 9 weeks. by ASHA workers or midwives, and then by trained doctors, I think, but up to 12 weeks. So apart from that, they don't have any word of abortion or anything. This is menstrual regulation. This is the method which they are practicing. It's quite unsafe because this is not a WHO recommended method. WHO recommended method is the medical abortion pills in first trimester. And obviously the facilities, health facilities are very much lacking over there in Bangladesh. Patients are also poor over there. We're not able to afford it, private hospitals. Tunisia and Ethiopia, these are two different countries in Africa. Tunisia, they have abortion laws which has been liberalized, like they can do abortion till 12 weeks. And Ethiopia, abortion laws are not there. They don't have any abortion laws. So all patients will land up in unsafe abortions. So they need to have decentralization of their health facilities, task sharing, they need to liberalize their laws. So all these things they need to do. So this was the striving towards safe abortion services in Nepal. There was a study which was done, a review of barriers and facilitators. So decriminalization of abortion in Nepal was done only in 2002. We had it in 1972. The financial constraints, unfavorable geography, lack of infrastructure, and social stigma as major barriers to safe abortion services. Economics and geography legalization, improved access, reduced cost, and active involvement of auxiliary nurses and midwives and community health volunteers are key facilitators which are helping this country to decrease unsafe abortion. So what does India needs? Dual strategy. Supply side, they should expand the access to safe services so that each and every woman in the remotest possibility of country should be able to avail safe legal services for abortion. Demand side should also improve. We should educate, empower, and destigmatize abortion in India. So India's strategy to decrease unsafe abortion, I've just made this. Legal framework, expanding access to safe services, strengthening health infrastructure, community awareness, post-abortion contraceptive counseling, and monitoring and evaluation. For legal framework, most of the work has already been done. MTP Act has been amended. And medical boards are being set up in all the districts so that even beyond 24 weeks where abortion can be recommended and should be done, there should be a way out. And protection of the privacy of the woman who is seeking abortion should be there. We should also train police, medical officers also on the MTP laws so that the extended umbrella of the MTP Act can be offered to all the women. Create zero fear environment for women, especially the young unmarried girls, single women who would seek abortion care. There should not be any stigma attached to it. They should not be able to access the safe legal services. Court directives promoting access, Supreme Court has already highlighted in a judgment. Public-private partnership should also come in so that safe abortion services can be provided to all, because most of the women goes to private sector for abortion. Less than 15 to 20% only goes to public health care. So there should be a public-private partnership model. When these nurses and midwives are trained adequately, along with linkage of referral services, so that if anything goes wrong, they can be referred. And now the provision of medical abortion pills, which are available, should be available to all women requiring abortion with certified facilities as well as by trained practitioners. Strengthening health infrastructure. We already have a health infrastructure in place. We already have CHC, we already have PSC. The framework is already set, but the only thing is not functional. PSC don't have doctors. So there are so many things that we need to strengthen our abortion services. We should ensure availability of equipment, medicines, and trained staff, and creation of medical boards, which is already being undertaken. Community awareness and education, I think this is one thing where we should, be aggressive about. We should have an aggressive campaign about abortion, what are the legal rights, since MTP Act has recently been amended. Availability of safe and free abortion services in government facilities, reducing the stigma, need of safe and effective contraception, and use ASHA for early pregnancy tracking of all women, if that is possible. IEC on legal abortion window and the danger signs should be available in the public domain. There can be digital helplines which can be there for abortion guidance, like whenever they need to, they find out there is an unintended pregnancy and they need to seek an abortion care, they can just dial and telephonically they can ask what are the services available, where can she go. Post-abortion contraceptive counseling, I think, is most important. So even in our day-to-day practice, whenever a person comes after abortion, we should counsel that contraception is important. Abortion is not a method of contraception. Promoting post-abortion family planning to prevent repeat unintended pregnancies, ensuring availability of a basket of contraceptive choices which we have, empower couples to choose the best contraceptive which is acceptable to them, and emphasize the need of consistent use of contraceptive and consequences and the risk of unsafe abortion. We should always monitor how our abortion services are going in the country. Like in PNDT, we have an HMIS system where we fill all the data. Similarly for abortion, we should be also having an HMIS system where we just fill the data and all the data is there, how the patient is following up, by giving this number like MCTS number is given to the antenatal woman. Similarly for abortion also, this should be implemented. Integration also is there, should be in HMIS reporting by various services, both in public as well as in private domain. Public health dashboard for abortion services should be done. Routine audits of maternal death linked to unsafe abortion and ensuring confidentiality and quality assurance audits of abortion services. So we have a scope of service enhancement. Immediate priority action should be that we should ask for an amendment of the MTP Act that we can authorize mid-level providers to provide medical abortion methods. We should ensure abortion services in all CSC and PHC should be functional. Mandatory post-abortion contraceptive counseling should be done and ensure safe use of abortion pills, and they can make a pictorial diagram of the WHO protocol on the combi pack, which will be very helpful to the patient, and digital helplines, which I just said. The partnership with Mary Stopes, EPAS, and FPI. FPI is Family Planning Association of India, which is already having many clinics in the country. Mary Stopes and EPAS, they are basically focusing on areas where they have very high amount of least effective unsafe abortions, like in Africa, Latin America, North America, and in Asia, where the unsafe abortions are very high. So we should be partnering with them so that we can reduce our incidences of less safe and least safe unsafe abortions, integrating the safe abortion services along with the maternal health, and strengthening the referral network. I think referral network is very important, especially when we are empowering the mid-level health practitioners for administering medical abortion pills. Then the referral services should be there so that if patient bleeds heavily, she should be able to go to appropriate facility. She should know where she should land up whenever the problem occurs. And the technology and telemedicine should come up. Till now, telemedicine, we cannot prescribe abortion pills. It is not allowed till now, but later on, we can be promoting that this should be done. We should be telling the healthcare administrators that MHF approved telemedicine for abortion up to 9 weeks with emergency care linkage. I think this is very important. And mobile apps for safe pregnancy termination information. And mobile health follow-up reminders for follow-up, for contraception. This should be available. So they're the bold 10 points action plan for Bharat. Ma'am has provided all the bold 10 points. Safe abortion in every CSC, empower mid-level providers, IEC campaigns in every district, free medical abortion pills at sub-centers, emergency referral linkages, telemedicine scale-up, zero stigma training, legal literacy for youth, private-public partnership, and post-abortion contraception as a rule. So no woman should die for seeking a service that is legal, simple, and life-saving. And investing in safe abortion is a human right, health, and economic imperative. No to unsafe abortion. Make every woman safe by safe abortion practices. Thank you.